Justin, thank you for coming in.
Thank you, Uncle Rich. Good to see you again.
Thank you so much, Uncle Rich. I love it. God, you've been in my life almost how long now?
Long time.
Right?
Very long. Since I was like high school, I think.
Probably even before that.
Yeah.
God. Yeah, you were probably still in grade school.
I was, yeah. I think I was in high school when my mom started like the whole real estate thing and met you and going through the whole spiel and whatnot. So
Jesus Christ, man, it's been a long time. It's great.
Yeah.
I got to experience you growing up, and now you're doing a podcast with Uncle Rich. Look
I
at
never
that.
thought I'd see the day.
That's so awesome. I'm excited to have this one on. I really am, because I am so proud of you and what you did in life and
Thank you.
And how you came up. And I'm so excited to just tell everybody, or you tell everybody about your journey, because I think it's really cool.
Yeah.
And it must have been torture living with Mom. She's, oh my God, the most perfectionist person in the world.
She's great though. She's great.
No, she's awesome. Without her, I wouldn't be where I am.
Of
So
course,
imagine you.
I wouldn't be here either.
That's that. So let's start out this. Where'd you grow up?
Yeah, so grew up in Queens originally from like I started out in Elmhurst with my mom, my dad, my brother. We lived at actually my grandpa's place on my dad's side in Elmhurst. I moved around from Elmhurst in Queens. Eventually lived in Forest Hills at one point. Did elementary school in Forest Hills, and then I think around like 5th grade, I was like maybe 10 at the time. That's when we moved to like Long Island, New Hyde Park area. Yeah.
And then ever since then, you've been in the New Hyde Park area.
Yeah. Since then, I've been pretty much in Long Island for the
Same
most
house?
part. Yeah.
Awesome. And then where'd you go to school?
I went to Great Neck South High School, so I was mostly stuck in the Great Neck region. I went to...
What'd you accomplish there?
In high school?
Yeah.
You know?
Did you hit your goals?
Yeah, I mean, at that time, I wasn't as I think I became very driven in college. That's when I really started my process. But like high school, I focused on my grades to a certain extent. I was really interested in like science, biology. That was my biggest interest, and that's why I kind of pursued a career in medicine, going forward. But
so how when did you realize that you wanted a career in medicine?
Yeah, I had a very different upbringing, with my brother.
Sure.
As you know, my brother's autistic.
Who is the coolest kid in the world?
Yeah, he's amazing. I love him to death.
He's awesome.
And he's probably the biggest reason why I went into medicine. Me taking care of him, my family, my dad, my brother, we all helped out and take care of him. And I grew curious of his condition. And then it kind of spiraled into me.
How old? If you don't mind me asking,
Yeah.
And I don't mean to dig too deep.
Of course,
this,
no, go ahead.
How old was Justin at that time?
How old was Jason?
Jason, I'm sorry.
Yeah.
Jason, how old was he? How old were you, Justin, at the time? And then how old was Jason at the time when he was
diagnosed? I think
we got interested in it. When
to
really realize it.
Yeah, I think pretty young. I would say around probably like 10. I knew my brother was different. I didn't really understand what autism was until later on as I got older. But I think around like 10, 11, 12-ish, when I was like maybe preteens, teens, that's when I started to develop an interest in neurology. I was like, oh, why does he think differently? Why does his brain work differently than us? And then it kind of spiraled into an interest in biology, how the cell works, how the body works, and into medicine essentially.
So if that didn't happen, you still see yourself in medicine? Or?
Probably not.
Really?
I really don't think so. I think he was a huge impact. Him, I developed a big sense of empathy, wanting to take care of others through him, and watching my family take care of him. I developed that background and that mindset. And I kind of applied it to biology and kind of mixed it together, and that led to that. I think I wouldn't have that sense of empathy or sense of caring if I didn't have that in my life. I probably would have went a different route, if that makes sense.
Sure.
So.
What do you, and I know it's hard to think. What do you think it would have been? Law or
maybe comp-sci, law, business even. But medicine really stuck with me because of my background, I would say. And that's kind of led me where I am.
So then take me through that. You graduate high school.
Yeah.
And now you go where? What college?
Yeah, I went to Hofstra University nearby in Long Island.
I know where you went. I just wanted you to tell it.
Yeah. But yeah, Hofstra University. I was a major in biology. I did a BS there, minor in biochemistry. I did a lot of lab work, like scut work in terms of I did research in microbiology.
What's scut work?
So scut work is like in a lab, I guess you could say. I did a lot of work in terms of growing bacteria. So scut work is when you actually do like hands-on lab work. So growing bacteria on dishes and whatnot. I did use the incubator. So I did a lot of technical things with my hands. So we call that like scut work in the
Why do you
laboratory.
do that? Like why Why are they doing that? Like, what's
Yeah,
the purpose
so
behind that?
you know, in I guess in the academic world, there's a lot of professors and doctors in the academic world that they do specific research. The one I was doing in particular was studying okapi. You know, we actually grew, they call it scat samples, but it was poop essentially.
Yep.
So we specifically did microbiology research where we were trying to find ways to grow biofuel through bacteria. So it was pretty interesting stuff. And, you know, we actually used like incubation bottles because the bacteria we were growing, particularly in my project, was they didn't use oxygen. So we had to keep them incubated in like a anaerobic condition where there's no oxygen. So, you know, there's a lot of different research studies with like mice and other stuff like that in the academic world. So that was, I partook in that during undergrad.
Okay.
Yeah.
You fall in love with that, or
You know, I did enjoy it for what it was, but in terms of, you know, having that, now that I have it now with my current job, but I didn't really get that personable experience for the, you know, a patient encounter, I guess you could say, or like developing relationships with people. It was more individualized or on a project base, so that's why I kind of leaned towards medicine, I guess you could say.
okay? So you
know,
graduate Hofstra.
yeah.
What was your GPA?
It was 3.8, not bad.
That's it? 3.8? You were allowed to get away with that with mom? Oh my God. She's sitting there laughing. She's gonna kick your ass, dude.
Yeah, I should have got a 4, right?
4.1, I'm surprised. 4.2, yeah. So from there, you took a year off.
Yeah. I
Why?
took 1 year off. You know, a lot of people take gap years, they call it, or like they take a transition period where I wanted to focus more on my application, wanted a little break from schooling. So it's a long process actually to apply to medical school. It's you have to take your MCAT. You have to.
How'd you do on the MCATs?
I did okay. I forgot. I honestly, it's been so long. I forgot my score, to be
Wow.
honest.
Wow.
Yeah, like I don't
Funny.
even. It's so far beyond me. Yeah, like because that was a while ago. Because
Yep.
and then because med school, as you know, is
When did you
pretty
take your
long,
MCATs?
too. When did I take? It was.
Were you still in college? when you took
Yeah,
it?
I was
You
still
were,
in
right?
college. So this
Junior
is,
year or senior year?
I was a senior, I think. So I
Okay.
was like 21 around that time. So
Okay.
maybe I'm 30 now. So like
Jeez.
9 years ago. This is a while ago. That's why I don't even
Yeah.
remember my score, to be honest. Yeah, it was a while ago.
Okay, so you
Yeah.
take that, and then you end up where?
So, you know, after you take your MCAT, you apply for med school, you do a lot of extracurriculars and whatnot. You apply, and then I took 1 year in between. So during that 1 year period, I guess you could say, that's when I figure out if I get accepted to med school or not. And
I remember, Mom,
Yeah.
you were always studying and also doing that too
Yeah.
during your time off.
yeah. Undergrad was tough. I studied a lot of late nights. I did
Yeah.
some all-nighters, you know, a lot of hours staying in the library and studying. I actually, you know, yeah, undergrad was a lot of studying time. Even med school was a lot of studying time.
What
so.
was more med school or?
Honestly, probably med school. Undergrad was a lot too. I did a lot more cramming, to be quite honest, but you kind of had to in undergrad. But med school is just, there's so much knowledge. Like, it's impossible to know everything about the human body. There's just too many systems. There's the heart, the lungs, the brain. So there's like, even to this day, there's no way any doctor can know everything. But we try to learn as much as we can to, you know, get to pass our boards essentially. So, you know, there's a period where in medical school, right? So it's a 4-year endeavor, right? So the first 2 years is mostly hitting the books, learning.
Take me through that.
Yeah,
Year
yeah.
one. Let's go
Yeah.
through this. Year one. What's it like? You
Yeah.
get into it now. You're
Yeah.
probably shell shocked when you go in there, right?
Right,
Because
right.
How much is it? How much learning is in that just the first day?
It's a lot. So just to put things in perspective, I was a biology major. We crammed all of that information I learned in undergrad into maybe 1/4 of the whole year.
It's crazy.
It's crazy. It's absolutely insane. You know, like the amount of information we learned. So maybe everything I learned in 4 years of, you know, undergrad,
You
like,
learned it
in like a quarter of a year. Yeah.
So now, how do you expect you to learn like all of that in that time? Like, what is it?
It's a lot. You get thrown in and they just say, good luck, essentially. I mean, you do have some mentorship, but,
Of course.
you know, medical school is a lot of individualized studying. Finding the right people to study with is very important. Having, you know, good, I guess, colleagues to work with, because you kind of rebound on each other. We formed a lot of study groups in the sense, but it's a lot of individual learning too, on yourself. And you just, you know, you go through the motions. Everyone gets through it. It's tough, though.
So your first year, what is that like? Let's go through that.
First year, it was mostly hitting the books, just learning, you know, general medicine, learning the systems. I would say the first half of the year was mostly anatomy. So we learned a lot of anatomy. We went through anatomy labs. So we had cadavers. So, people donated their bodies for learning. So we would, go to the anatomy lab, dissect body parts, look through all the arteries, veins, the organs, every part of the heart, every part of the brain.
How many people,
yeah.
It's probably a silly question, but how many people get so squirmish that they drop out at that point?
It's a good amount of people. Like, I wouldn't say maybe less than a quarter of the class probably, drops out eventually. It's not easy, but
how about the first year?
First year, I would say maybe 10 to 20 or maybe even a little less than a quarter, yeah. Because our class was pretty big too. Our class was maybe 300. I can't say particularly how much exactly, the exact number of how many people actually dropped out, but it was,
of course not, yeah.
But I would say maybe like less than a quarter of the class, yeah, out of 300 maybe.
So you're actually like, I didn't go through anyway what you went through, but as a cop, we had to go through that. We had to go to the morgue and we had to look at the bodies and all of that crap.
Right.
Doing an autopsy or whatever. You're actually doing all of that stuff in your first year of med school.
Oh, right off the bat. That's the first thing we get thrown into, yeah. So we see everything. We open up the body, we see every organ. We had anatomy lab, we had tests on it too, where we literally walked through the anatomy lab with a piece of paper. We'd write down our answer. What body part is this? What artery is this?
Oh, wow.
What does this innervate? What does this supply? So it's a lot. It's a big investment in the beginning. It's even just the first year of medical school. But
wow.
Yeah.
How many? What's the classes like? How many hours? How long are they? Like, what is it?
Yeah, it's pretty
What's
long.
A day like?
Yeah, the day. So it depends. There's a lot of individual learning. My school is probably very different from others because I happen to be in the era where there was COVID. So we had a lot of.
Is that a good thing or a bad thing?
It's hard to say. It's different because you don't get the interpersonal relationship. It's a lot of videos. You just watch a lot of pre-recorded videos, to be honest. Some people, sat into every lecture. So we had lecture every morning for like 4 or 5 hours every morning. That's how it kind of worked. And there would be breaks in between.
So your first year was the first year of COVID?
Actually, I think I was in my second year of med school, or like in between the transition of second and third year, where COVID hit. So it was during my second year, actually. Yeah.
Interesting. Did they call any of you guys up to like help with the front lines?
No, but I think, it was mostly the residents who had to stick up. So I actually I was like at the very end of COVID, I guess you can say. So I didn't get hit by it as much as when I was working as a resident. But a lot of residents at that time took the toll, I guess, or took the weight of COVID in the sense, and it was tough from what I heard. A lot of my seniors that I worked with as a resident that graduated already, they worked during the heat of COVID, I guess you could say, or like the peak of it.
Wow.
Yeah.
Okay, so you get to your second, your first year is tough.
Yeah.
You get through that, or you saying, okay, I got this, or is it like, oof.
It was tough in general.
And then how much is your break in between? Like, what do you get?
Oh, so like in terms of breaks, like, yeah. So first year, it's learning. You're kind of throwing you into it. You're trying to, get used to, I guess, medicine in the sense and get used to medical school. You're putting, take off the training wheels. And then second year is really where the brunt of the studying is because that's when you're studying for your boards. Other medical.
Second year is your boards.
Yeah. Second year, you take your boards at the end of second year. So like the first 2 years, you're hitting the books. Second year, you're really hitting the books and really studying. And that's actually when COVID hit around that time. And I was stuck inside just literally studying like 12 hours, 10 hours a day, just doing questions, studying material, watching videos.
So it probably helped you in some sense because you weren't going anywhere else.
Yeah, in a sense, but I also felt like very enclosed. I could not leave the house. Sure. I like studying in the library, like changing the scenery. So it was tough. It was that was the most studying I ever did in my life. During that second year of medical school.
And that's the boards. Okay, so how'd you do on those, obviously? You did okay?
Yeah, I did good. I did okay, yeah.
You have to hit a certain score? Or?
Yeah, so there's a certain passing score, and then, based off your score, it kind of dictates where you can go in terms of specialties and whatnot. So certain specialties like orthopedics, for example, requires like a higher score. Score is not everything. Obviously, extracurriculars, take into account, and they look at the whole applicant. But they do. The board score does matter a good it's a good part of it in terms of where you end up and what type of specialties you wanted to do. I particularly didn't want to do like orthopedics or like surgery. I like the patient I guess, the patient interaction and the patient-doctor relationship. So I went into primary care essentially. But
Primary.
yeah,
And I remember it was a time when you were deciding what you were looking to do. I guess that's the
yeah,
second year.
exactly.
I
So
remember that,
yeah, exactly.
What were you thinking about back then? 'Cause I remember a couple of them. I think one was, God, what were they? Mom coming to me and talking to me about it. General medicine was the one, right? She said you were torn with orthopedics, I think, at one point.
Oh
right?
yeah, maybe sports med.
Sports med, that's right.
Sports med's very interesting. I couldn't see myself doing it long term though, because you just focus on MSK, which is musculoskeletal.
Yep.
You only focus on injuries and whatnot. You don't see anything else. You just do injections. I was thinking about being like a non-surgical, like essentially orthopedic or sports med doctor, but I do like having that patient relationship. I feel like you don't get that in sports medicine.
And then wasn't it like facelifts at one point? You were looking to get into the beauty part of it?
Aesthetics, that's
yeah.
still an option in the future. I was thinking about, aesthetics medicine. So that's more like injections of the face, keeping, it's more aesthetics, as you can say.
Sure.
Yeah.
But you have to be licensed as a doctor to do that? Or
Yeah, you need to be a physician. So how it usually runs is like for an aesthetics clinic. So they're becoming a lot more popular. It's very popular in Asia, actually, and now it's becoming more popular in America.
States, yeah.
These days, where you can literally just go to a clinic, you pay out of pocket, but they give you special injections to keep your face looking younger. There's a lot of different treatments for the skin. That type of thing. That you need to be a doctor, and you need like a certification, not necessarily a fellowship, but you do have to do like a short like training process, which is not too bad.
Okay.
Yeah.
So you get through your second, third year comes, what's that like?
Yeah. So third year is when you go into rotations and you actually physically work, I guess you could say, or witness, shadow.
So it's 2 years of classes.
Yeah, exactly.
Third year's of rotation, so
Yeah.
you're actually in the hospital. Where'd you go?
Yeah. So I went all around like Queens, Brooklyn, even Long Island. So I went to NICOM, New York Institute of Technology, College of Osteopathic Medicine, and after the first 2 years, like I said, you hit the books. The third and fourth year is when you go out to rotations, we call it, and you actually go to the hospitals, work with other doctors, work with residents.
Can I ask you a personal question?
Yeah.
Are you getting paid at this time, or you're not?
No, not at all.
So you're doing it. It's basically you're doing it on your own.
Yeah, you're paying for it. So for the 4 years of med school, you're paying for the whole process.
Even the work. Okay.
Yeah. So you're working under residents a lot of the time, or working under attendings. This is where you learn like hands-on experience. You can assist a doctor with doing a surgery. You can go to rounds, present patients. It's more like the hands-on experience, I guess you could say. That's what third year was mostly focused on, and
What's that like?
Yeah, it was a lot because it was a lot. It depends on what rotation you're on, because some rotations are really tough, like surgery, for example, could be really tough, or OB-GYN is really tough because they have like tough shifts. So you would be there when the residents are there, and you basically follow them around, do what you're told, you learn from them, you try to ask questions, and you can assist with procedures and whatnot. So that's where the learning comes in. But you also help a lot with them as well in terms of seeing patients, helping out with presenting patients and getting information and whatnot.
So interesting. Okay,
Yeah.
so where did you say where you were working? Like what hospitals did you went to?
Yeah, so I went to a lot of different hospitals. I went to Good Sam. I worked at the NICOM clinic. I went to Wyckoff Hospital in Brooklyn. I went to
A lot of traumas, or
yeah, I was in the emergency room at one point. I did psychiatry there. So I was in Brooklyn for some of the rotations, essentially.
what's that like?
It was tough. You see a lot of stuff.
Yeah,
like,
no,
like
I can imagine.
You see a
Sure,
lot.
you're getting gunshots.
Oh
car
yeah,
accidents.
yeah, 100%. You see all that type of lack of a better word. You see some shit like gunshot wounds, patients coding on you, dying left and right. You're doing chest compressions, helping out with that.
How do you?
Yeah.
Again, being a kid that cares, right, so much. How do you separate that, like that? Because again, even as a police officer, that was difficult for me. Like, when you have these people going through their worst time of their lives, and
of course
you're there to save their lives, obviously.
Yeah.
And it doesn't happen.
Yeah.
What do you feel like at that moment? Are you?
It's tough. I would say, even during my first year as a resident, like it's a transition. When you see someone die,
especially your first year.
When you see someone die for the first time, you never forget it. You know what I mean? Like, it's hard. you have to get used to it. I think it's you kind of unfortunately have to develop a little bit of separation, you know, from your emotions to the actual job, and it's sad because you feel bad. You know, as a doctor, you want to save people, and our sole job is to save people. But a lot of the time, you cannot. You know, there's a lot of situations where there's nothing you can do, and you kind of had to just accept the fact. And it takes a long time to accept it. Did they train
you to get hard, or did they, like with us? I remember it was just like, all right, deal with it.
It's kind of just deal with it.
I was nowhere near the level that you're in. You see everything.
Yeah, you kind of just deal with it, to be honest. Like, you get thrown into, like, residency is a whole nother animal. You just get thrown in, and you kind of, you adapt and survive, essentially. You get used to it. I think after seeing it over time, you get used to speaking to patients. You get used to seeing death, unfortunately, and you kind of have to, you still have to care, and you still have to have that empathy, but you have to also, I guess, separate your emotions at times and understand the objective goal in that regard.
So, silly question: if you're going orthopedics, you still have to go through all of this.
Yes. Yeah.
No matter what.
Exactly. So, like, orthopedic residents still have to go through medicine rotations. They still end up, as a resident, they still take care of these sick patients, or they work in the ICU too. I actually worked with a lot of orthopedic residents during my residency program, where we, you know, I guess we kind of transitioned, and we would work side and side a lot of the time. But they would focus more on orthopedics, but they would have certain times where we work together. Yeah.
So if they're an orthopedic residents, you're working side by side, but they're also focusing on the orthopedic side.
Yeah, exactly. They'll do rotations.
So with an ACL, they're gonna be the ones working on me most likely.
Right, exactly. But like, for example, they have to do like a month rotation just for the learning process in the ICU, for the intensive care unit.
Okay.
Where, you know, that's where you see really sick patients that are on death's door, essentially.
Why did they make you do that? Is it just so you know every little?
Yeah.
I know it's a silly question, but
yeah. I think, you know, as a doctor, you want to have a broad knowledge. You want to have experienced everything, so you know what to expect, so nothing is a surprise to you. It's also a hospital thing too, right? Like, the hospital's understaffed. As you know, the medical field is really understaffed. Not enough doctors, not enough nurses, just not enough staff in general.
Why is that? Is it a good thing? And again, it's a silly question. Another silly question. Is it a good thing that it's understaffed? And why is it understaffed?
Yeah, I mean, there's a lot of different barriers for medicine, right? One, no one wants to do the job. Medicine, it's really tough. Imagine seeing people die every day, taking care of patients. It's a lot of, you have to have a certain mindset towards it. Also, not a lot of people can handle blood. Not a lot of people can handle that type of thing. And also, in terms of getting to med school, it's really tough. There's a lot of different barriers that you have to cross, or a lot of different, you know,
which is a good thing.
Challenges. Yeah, of course, you want a competent doctor, but, you know, financially speaking too, there's a lot of, you know, med school's not cheap. It's very expensive. A lot of people can't afford it.
What do you think that would ever change? And again, a bunch of silly questions here for you today.
Yeah.
Do you think that would ever change with the financial part, where you think they would sit here and say, okay, let's waive the tuition for these guys and find a way to pick that up because they're doing so much? And
it's hard to say. This right now is not looking.
It's not gonna happen.
It's not looking like it's heading towards that direction. If anything, it's getting harder to get into medical school. You require a higher GPA. You require a higher board score to get to a better fellowship. You know, it's getting more and more expensive for medical school in general, and there's just so many barriers, and no one wants to do the job anymore. It's a hard job, and we're not getting properly compensated, in my honest opinion. And I would say a lot of doctors would agree. The pay for doctors for the amount of work we do is not up to par, I guess you could say.
So what's in staying your third year residence? How many hours you working? Is that where you're working 18-hour shifts?
Yeah, so I work in like 80 hours a week. I did like at least sometimes I would do like 2-week or 4-week blocks where I would work 13 hours a day, like on night shift. That's at my hospital. The residents do nights for like 2-week rotations. So I would be doing.
Is that 2 week?
Yeah, 2-week rotations. A lot of residency programs do like 4-week rotations. So you would be on the night shift, or night float, we call it, for 4 weeks at a time, which is a lot.
What's the hours from that?
For my particular hospital, it was 13 hours. So I would be working 13 hours, 6 days a week.
So you're coming in at midnight? Or
I'm coming in at 6 p.m. and I get out at 7 a.m. the next day. Yeah.
Wow.
Yeah. And some shifts are very easy, but most of the shifts are tough.
You have a place to lay down, relax? Or?
Yeah, we have a bed, but a lot of the time I didn't sleep. I could never sleep in those beds. They're very uncomfortable. Some people could. They were really good at it. But, you know, there's so much stuff that's happening at nighttime because at my hospital, there's only a couple residents and maybe one or two attendings that were really covering all the floors of the hospital. So, and we had 300 to 200 patients in my hospital is pretty small where I worked at Plainview when I did my residency, but you know there were a lot of patients that I had to take care of during nights, and it was only like a couple of us, like 4 or 5 of us, that really covering the floors for any emergencies.
So now this is still when you're in school.
This is during residency now. So
residency.
Yeah. So this is so you do 4 years of med school, and then I did 3 years of residency after.
Oh, so this is after the med school.
Yeah, this is after med school.
But at least you're getting paid at residency.
Yeah,
right?
so I'm getting paid, but not much. You're a doctor and you have your license. You have your doctorate, but you're still in training in a sense where you're still working under another doctor, which we call attending.
So before we get there, what was the 4th year like?
Yeah, of course. So, you know, 4th year was more, you were trying to focusing on, you're still doing rotations where you visit hospitals and whatnot and work with other doctors. But that's where you get to focus on what you want to, I guess, specialize in. So other doctors or medical students would be like doing rotations. If you met, for example, if I wanted to do sports med, I would do rotations, or like orthopedics. I would try to, you know, pick rotations where I work under an orthopedic doctor.
Now, do you go like, all right, I'm going to work with NYU now, and
exactly,
HSS or wherever it is, that's where you're going to go to work.
Right, exactly. So I try to do rotations where I potentially wanted to work as well. So like we call it audition rotations, where you actually try to pick rotations that you want to potentially do residency at, where you want to work at long term. And that's what I did. I did a lot of rotations at hospitals like nearby in Long Island because I wanted to stay nearby with family and whatnot.
Sure.
I really liked Plainview in particular. Plainview Hospital had really tight-knit community, very good residents. The staff was great. So I did my rotation there as like an audition rotation to try to essentially show off and, you know.
So what is that like? You're in your first year, like your last year of school.
Yeah.
You're basically doing whatever you're told.
Yeah.
At this point. So
right.
you're learning it. Are you doing most of the work, or?
I would say you're picking up some of the work. It depends on like which rotation. Some rotations require more, I guess, more workload, or you're picking up more of the slack versus others. My rotation, I would pick up a couple of patients at a time, maybe 2 to 3 patients out of like 16, for example. Usually a census on a medicine team is like, at least at Plainview Hospital, was 16 patients, roughly speaking. So I would maybe take like 3 to 4 patients and, you know, present them and, I guess, make a plan for them essentially. So I'll be kind of the transition from working, you know, to a resident is kind of that transition period. But, you know, you are picking up patients at that time and trying to take care of them, yeah.
Okay, so we finished our 4 year. We're in our first year of residence. What is that like now? You come into your first day, you get your hospital, or you can still get assigned to other places? Yeah,
so how it works is, you know, from 4th year of medical school, that's when you apply, we call it the match. So you apply, you rank your top hospitals that you want to work at or top programs, and you hopefully get your, you know, they rank you as well. So the residency programs rank you, and then you rank them, and then if you get lucky, hopefully you match each other, and then you match with that program.
Anybody not make it?
Yeah, there's a lot of people who unfortunately don't match, and they have to apply again, or they look for a different profession because it's tough. It depends on what you want to do, obviously. Some people go for very competitive specialties, so it's really hard to match. And then people go for easier residents, I guess you'd say. It depends on what you want, but definitely, like, depending on the specialty that you go for, it could be really difficult to match with a program. So you might be jobless at one point, and you may have to apply again or whatnot. It's a very tough process. At that time? If you don't match, yeah.
Like, what, you just hanging around?
You're just hanging around, doing research, trying to build up your resume, essentially. Maybe do more rotations, but usually it's like research.
Still going to rotation.
Yeah, you could find a way to maybe find work or find some side job or something like that in the meantime. It could be difficult, though. I thank goodness I didn't have that situation, but it could be very difficult. The whole process itself is very grueling.
So what was your first choice? Plainview?
Plainview, yeah.
Did you get it?
Yeah, I got it.
So you get it. What's that first day like? You get in, okay, I made it.
Yeah.
I'm at residence. I'm making money. I'm a doctor.
It's surreal. It's
holy shit. I'm not.
It's holy shit. It's a holy shit moment for sure. Lack of a better word, but it's scary because you're now in charge of the patients. If you do something wrong, it's on you. The patient could die if you make a wrong mistake.
Let me ask you another silly question. Who's picking up your insurance at this point? Is it you?
The hospital.
Or is it the hospital?
The hospital, yeah. So the way residency programs work is usually the hospital system or the program then provides you insurance. You're not paying, for yeah, exactly. So you're covered by the hospital, but you still don't want to mess up or do anything. Not. Yeah.
So now you're in that rotation. You get a guy that comes in with a torn ACL.
Yeah.
You got an ACL, you got somebody with a flu, you got this. You're dealing with all different problems. Right
everything,
now. And then a gunshot comes in, right, to really throw things off. Now you run into the gunshot. Does it all take priority? Is it first come, first serve?
Yeah,
what is it like?
It's priority. It's like whoever's the most, whatever the most severe case, you put that first, obviously. It's not first come, first serve. It's whoever's the sickest, you have to take care of first.
Okay.
That's how it usually works, especially in the hospital setting.
So the orthopedic side is probably the worst to be in if you're a patient. You're going to be seen last.
Yeah, unfortunately. Like, it depends.
Like a sprained ankle or something like that?
It depends because we do have orthopedic. So the work is split up amongst a bunch of different residents, a bunch of different specialties in the hospital. We have orthopedic residents that handle the orthopedic side. So I actually didn't really see much of that. I did have patients with orthopedic issues, but I mostly took care of the medicine aspect, like heart issues, lung issues, in that regard, like heart failure and whatnot. But
so what's the average age that when you're in there you're seeing coming in? Is it the elderly?
Yeah, I mean, it depends on what hospital you're in.
Position.
Yeah, in my hospital, it's almost like a geriatric hospital. Plainview Hospital had a lot of elderly patients, a lot of like heart failure patients, a lot of heart issues, kidney issues. It was mostly like on the older side, I would say. We did have younger patients come in with issues as well, but I tend to see on the older side like 70s to 80s, 60s, maybe even 90s to 100 years old. Wow. Yeah. But I would say majority of our patients are on the older side for sure. Yeah.
Okay, so again, you're going through all of this and you're dealing with this and you're running around like crazy.
Yeah.
Is it one of those things you come in at 6 at night and it's now 7 in the morning like that?
Yeah.
Because it goes that quick?
It does. It's just like that. It depends. Some nights are really slow.
Oh,
there's slow nights. Yeah. So it's a mixed batch. I was known as a black cloud of my program, which means I'm the guy who
gets all the shit.
Gets all the shit, exactly.
You're
all
getting
the bad
gunshots in Plainview.
Mostly cold blues, mostly patients heart stopping, and I have to do chest compressions. But yeah, like we would have nights where like nothing happened. I would just sit there, just relax, no calls, nothing. And then I have other nights where this patient's coding, this patient's bleeding, this patient's blood pressure is tanking. He's about to die. He's septic. And
so
then
what do you do?
Yeah.
Like what's going through your mind?
It's tough. It's a lot of managing, it's prioritizing. It's a lot of multitasking.
You just can't call mom.
No, I couldn't. I wish I could have.
You can't do that. Right?
No, you can't. You can't. I mean, I had my attending to help out whenever I didn't know what to do. But as you become more senior in residency, so as you progress through the years, you're like a second year resident, third year resident. When, as a senior resident, you have to take more responsibility.
Sure.
And you have to learn how to handle these situations. You see a lot of the situations again, like similar situations, like you'll see your heart failure patients all the time. So you kind of know how to manage them, but every patient's subjective too. So it could be very different. Like some patients
you just said something. So is all heart attacks the same, or is it treated the same, or is it?
No, it's different. There's difference between heart attacks, heart failure. So if you have a heart attack, there's different categories of it, but like a heart attack itself is when a artery is like completely blocked that supplies a portion of the heart. A lot of the time they put a stent in, but if it's really bad, where it's like multi-vessel disease, where there's multiple vessels blocked off, they might have to do a CABG, which is like a bypass surgery. So, it really depends on the patient. There's a lot of different avenues of treatment. There's broad, like, I guess, algorithms, but it does depend on, it's very meticulous. Yeah.
So what was your first stent that you put in? Did you ever do it?
I never put in a stent. That's usually cardiology, but, I did have heart attack patients, or like we call it acute coronary syndrome, or patients with like heart issues that needed a stent. I did take care of them from the medicine aspect. I didn't really do the surgical. I was more the medicine. Sure. So we handled like prescribing medications, putting in orders and whatnot, and managing the patient as a whole. And then we would have cardiologists. Yeah, so like there's so many different specialties. It's a team effort, right? So
is there a cardiologist always on
site?
Yeah,
exactly. So there's always a cardiologist on call at my hospital.
On call, not
yeah.
on site.
On site too. So usually there's a cardiologist in house throughout the day. Usually just one cardiologist, and he has mid levels under him, like a nurse practitioner or whatnot that works under him. But it's usually just one cardiologist, and then we have some interventional cardiologists which specifically do like interventions or surgery. But a lot of the time we would work hand in hand with the cardiologist. Like we would manage the medicine aspect and manage the other aspects, while they would focus specifically on the heart. So it's a team effort with all different types of doctors, kidney doctors, gastroenterologist, like stomach doctor, intestinal doctor, like surgery.
And then are you picking up, probably a silly question again, are you picking up clients or patients?
Yeah, so
when you're in the hospital?
Yeah, we are in a sense because, my program is family medicine, right? So we do a lot of outpatient as well. So we would refer our patients that come to the hospital, we would refer them to our outpatient clinic so they could follow up at the clinic that I work at outside of the hospital. Because after you leave the hospital, you need to follow a doctor outpatient, right? So,
that's what I'm saying, yeah.
Yeah, so we would try to refer them to our clinic, and then we would see them hopefully in the clinic after.
But you're not going there as a resident.
In the clinic, I worked there too. So
you do?
Yeah, so we did both. We did hospital work and clinic work. We kind of did hand in hand. We mix it up. So you get a little of both. Yeah.
So what's the clinic like?
Clinic is, I would say, it's definitely less intense. You see patients that are stable; they're not like acutely sick and dying on you. But you're managing all their chronic issues, making sure they're not going to the hospital again. So I have to manage their medications, make sure they're on the proper regimen, make sure they're seeing the proper specialists, making sure they get the proper vaccines, making sure they get the proper healthcare maintenance in terms of like getting a colonoscopy, checking, breast mammograms and whatnot. We're doing the whole workup to make sure these patients are long term going to survive longer, have a better life and not go to the hospital as much. So that's our role as an outpatient perspective.
Okay.
Yeah.
Let's go back to the hospital. When was the? Do you remember the first time? If you don't want to talk about it, just tell me no.
Of course.
The first time you did save a life?
Yeah. I mean, I'm trying to think.
And what does that feel like?
It was rewarding in the sense that I was able to. So it was a patient in the ICU. I remember he was very sick. Unfortunately, this patient wasn't going to last much longer already. He was actually brain dead. He went into called diabetic ketoacidosis, which means when you have diabetes and your sugars are so uncontrolled, they can cause all your organs to fail. It was to the point where it was out of control, the diabetes, right? And it could be life-threatening. He unfortunately didn't get treatment enough, and we already suspected he was brain dead. We had imaging studies that kind of confirmed it, but the family didn't want to let go yet. So it's kind of a mixed thing where you have the family involved. You have to make sure we follow their wishes. I was able to do chest compressions. Me and my fellow co-residents were able to bring the patient back to life, but he only survived maybe a couple hours after the fact. It was kind of, we knew where it was going to head. And then I think he eventually passed later that day, unfortunately. But that was my first time. A lot of the time when you bring a patient back to life, they're not going to talk to you and be like, oh, thank you for saving me, because they're still going to be likely intubated or sedated or unconscious, or their brain's just not functioning yet. But long term, it could be rewarding. We do see some patients come back after that and like, wow, you saved my life. Or I've had some great experiences where I've helped patients out and they're very grateful for what you do.
Sure.
Yeah.
Saved my life. Shit. It's the ultimate, right?
Yeah, yeah. And then, it's rewarding in that regard, I would say.
So now where are we at? What are you doing now?
Yeah, so, now I finally finished residency, 3 years, where it's intense, working in the hospital.
Before you go there, what was your craziest night, do you remember?
Sure.
In an ER or...
Yeah, craziest night. Let's see. I could tell you about one recent. There's one recent code blue that I had. This patient in the ICU. She was completely fine. She came in for a GI, I believe we call it a gastrointestinal bleed, where she was bleeding in her intestines. No, don't worry about it. I didn't even notice. I was just talking.
Yeah.
But, so this patient, was recovering from a gastrointestinal bleed, and all of a sudden, she just started gushing blood out of her mouth. Just pure blood good everywhere, and she coded right on the scene in the ICU. This is an intensive care unit. She was already there. And my intensive care attending was still there. It was like at 8 p.m. It was actually past her shift, and a cold blue was called. It lasted like 30, 40 minutes. We were doing
40 minutes.
Yeah, we were doing chest compressions on this patient that we essentially knew was probably going to die, but it was just out of the blue. She looked, with medicine, it sucks because you don't know what's going to happen. Some patients look completely fine and they can crash out of nowhere. Wow. And that's what happened with her case. She she was fine, and then suddenly, I guess maybe she had a rupture of an artery or something in the esophagus, maybe started bleeding, and she was just gushing blood. And we did all we could to give her blood. We did chest compressions. We even did we did all we could in terms of like doing an IO, where we actually put it's interosseous. We couldn't get I guess. What's the word I'm looking for? I apologize, but
you're asking me.
We couldn't get IV access is the word I was looking for. I'm sorry. So
okay.
yeah, we're trying to get IV access because we're trying to give her more blood. She wasn't getting enough blood because she was gushing out blood. So we were trying to give her, I guess, pack red blood cells or blood transfusions. And we actually did an IO where we actually put a device into her bone so we can give her some more blood.
Wow.
Yeah. So we did all we could to save her life. I was running the code at one point, doing compressions on top of it. We were taking turns. It was very chaotic, and we did all we could, and it was unexpected, but we couldn't save her. Yeah. Unfortunately, it's hard. And she seemed like a very nice patient. I spoke with her very briefly, maybe beforehand, but it's
insane. You're talking to somebody, they're fine.
Yeah.
The next minute
they're just gone. Yeah, and the family was devastated too, because you try to give good news to all your family members that you're helping out, right? But sometimes you have to give really bad news, and it's tough. Even I haven't mastered that yet. You can't just use an algorithm to treat a patient. This patient that I'm looking at one day may be having heart failure and look completely different from another patient that has heart failure or is having a heart attack. This patient could be having jaw pain and arm pain. That could be having a heart attack, for example, and then I have another patient, no symptoms at all, but the troponins which is a marker for a heart attack, are super high. There's certain things where AI would never be able to replace, especially in from medicine aspect.
Wow.
Yeah.
So that was the most hectic. Like, how about car accidents and
stuff
like that?
Yeah.
I was talking to a doctor a while ago, and I remember me and him were driving together, and he wasn't too happy with the way I was driving. He was trying to explain to me how bad it is to be in a car accident.
Yeah, car accidents are horrible. They're horrible for your neck. Motorcycles scare me now. Like it's gruesome. Like I wouldn't wish that upon anybody. Just you could ruin your whole life. You could be paralyzed for life from like just a bad accident.
Wow.
And it's scary.
And again, like, what are the craziest things that you see? Like, as an attendee, I guess, like, or residents, like, you have to see some. Like, as a cop, I saw some crazy shit.
Yeah, I've seen some crazy stuff. I've seen, like I said, blood gushing out of a person's mouth. I've done chest compressions on an elderly lady where her ribs are literally sticking out while I'm doing chest compressions just to save her life.
Wow.
Yeah, I've seen nasty stuff too, infected wounds that you couldn't imagine of.
Where does that all come from?
It depends. There's a lot of different causes for everything, right? But like infected wounds, a lot of the time it's like patients who don't take care of themselves, or they're diabetic, they don't take care of their diabetes, they have poor blood supply, vascular disease it could be genetic, it could be just poor lifestyle where they don't eat well, and it catches up to them, and we see a lot of that type of stuff.
Wow.
Yeah.
And then how do you tell them how do you tell somebody that that you got to do this, or this is going to happen? Like, what?
Yeah.
Like, how do you learn to do that? Like,
it's experience. There's no way anyone can just do it right off the bat. I think it's more just watching and learning from your mentors, and then you do it yourself. It's learn one, do one, teach one. Right? It's kind of just like that. So like over time, I learned how to give bad news to patients. I learned how to educate patients, but it took a while for me to get used to that. I think it takes a while for everybody.
Crazy question too. Is it hard sometimes to give good news too? Like when somebody's in bad shape, that you give them good news, but it's still bad news? Does that make sense?
Yeah, it depends. It depends on the family. It depends on who you're talking to, right? Some patients want to know everything. Some patients aren't happy with the news you give them, even if it is good news. I tend to find giving good news easier, obviously, than bad news. Yeah, and I find it easier. Like, oh, your father's gonna live. Oh, your father's doing better, or your mother's not doing so.
But something like this, where your father's gonna live, but he's gonna be paralyzed from the neck down.
Yeah, that's bad news, and it could be hard to give. Definitely,
right? It's obviously bad news, but it's good news that he's gonna make it, though.
Yeah,
It
depends.
So
So
have you ever got stopped in the street or noticed outside of work?
I'm trying to think. Maybe in the hospital, not particularly in work, But I've been like noticed by patients that I've taken care of in the past that maybe I'm not taking care of anymore, but they happen to be in the hospital again or around the area. Yeah, so mostly in the hospital they would recognize me.
It was a good experience.